All right, gang, we're going to talk chapter 8 and focus now on inpatient care. We talked in last chapter about outpatient care. And of course, there's a lot of overlap in how these two things have evolved, as we talked about in the outpatient care segment. But I want to bring back this slide that I showed you in previous chapter. This is the hockey stick of economic growth, just to refresh. So going back to like 1,000 years ago to 1000 AD, coming forward to the future, how poor everyone in the world was, right? We were living on something like $1,000 a year, almost everybody. And then somewhere around the 1700s, we had the Industrial Revolution and the Enlightenment, and incomes began to just take off. And so relative to all of human history, by about 1750, we started to see an explosion in wealth of the human species. And today, the average person living in the West has an income that is 40 or 50 times what our ancestors had back in, our average ancestors had back in, say, the 17th century. So not that long ago. So I've been talking about how wealth and finance have an impact on health, right, and the delivery of healthcare. So I've made this very busy slide, so I'm going to try to walk you through it and kind of tie the economic growth to the evolution of inpatient care. But we're going to talk about a few other things on the journey. So the way I look at the period of the Middle Ages or the medieval period, which is what we look at, fall of Rome, so around 400 to around 12 to 1400, depending on where you are in Europe. So this is Eurocentric perspective. We had kind of a period of traditionalism. So not very much changed. If you were born in 1000, or you were born in 1200, or you were born in 1400, technology didn't look a whole lot different. The things that you did, basically your grandparents did. You ate the same things, you wore the same kind of clothes. There was kind of turmoil there, but basically it was just rearranging the deck chairs and not much changed. So science didn't really exist, right? What we had instead was tradition. And whatever the Bible told us, whatever the church teachings told us, whatever our grandparents told us, that's what we took as, quite literally gospel, right? But that's what we took as, this is knowledge. This is what we have. And as a society, we frowned on innovation. So you may know stories about Copernicus and Galileo and how they wound up getting into trouble for saying things like, the Earth isn't actually at the center of the solar system, the sun is, right? But that's pushing into the Renaissance, right? So the transition between the period of heavy tradition into the Renaissance. With the Renaissance, what brings on the Renaissance, and you can argue about this, but what brings on the Renaissance is actually a health event. And that health event is known as the Black Death. A lovely title, the bubonic plague. So this was an enormous pandemic that swept through Europe for about 5 years, from about 1345 to 1350. If you look at the art of this period, there's lots of horrible, scenes of devils killing people. And our poor ancestors had no idea how the plague was transmitted. They thought it was, spirits. They thought it was humors. They thought it was the cats. And so they killed the cats. How it really was transmitted was through fleas that jumped off of the rats and mice that lived around them. So when they killed the cats, because they thought the cats were the problem, they were actually killing one of the things that was keeping it kind of in check to limited degree. So the bubonic plague was spread by fleas, right? So very poor, right? Remember, we're living in a very poor period. Even the wealthiest people probably had fleas and mites and all kinds of nasty, creepy crawlers all over their bodies. And so nobody was exempt from the Black Death. And by the end of about 1350, half of the population of Europe had died. Right? Just imagine that. Like COVID, we just had flow through here, and we lost 500,000 people out of 300 million people. Imagine if every other person, if every other person disappeared, like out of a superhero movie that just, Avengers Endgame or whatever it was, right? With the bad guy snaps his fingers and half of the universe's population disappears. So this was a bit more messy. People didn't just disappear; they died horrible deaths by the millions. But what happened as a result of that was a lot of changes that I'm not going to go into here, of social relationships. But what brought on it upset the traditions, right, and brought on the Renaissance to a certain degree, and we began to look at the learning from the Greeks and Romans and how they actually had science, and they actually used reason, and they actually did a lot of empirical work. So empiricism, you're looking at the world as it is and trying to understand it. So during this whole period, we had social organizations, right? So we had the church, we had a lot of civil society organizations that tried to provide sort of a social safety net. Now, it's a really bad, really unpleasant social safety net. But the reality was everybody was so incredibly poor that there just wasn't a lot of excess to go around for people who couldn't care for themselves, right? The average person was on the verge of starvation at any given time. People regularly died of starvation during this period, right? If you weren't a wealthy landowner, you had a very high probability of dying of starvation or dying of a disease that was related to malnutrition. But we had these organizations that were almshouses, poorhouses, that kind of generically took care of the poor, the sick, the dying, the disenfranchised, and so forth, right? So we had this, through this period, we just, because of the level of poverty, there wasn't the technology, there wasn't the support, right? People did the best they could. And then the Renaissance kicks in, and we begin to have this kernel, this seed of reason, the seed of empiricism again. And that begins to build as we look back past this period of tradition, back to an even earlier period, right, where people were actually scientists, right? The Romans were an amazing engineering society. They were the utmost engineers. If you ever get a chance to go to Rome and walk around and see some of the structures that the Romans built 2,000 plus years ago that still work very nicely, like all the fountains and some of the aqueducts and the roads, and it's just incredible to see, right? So we started to, as a society, we were like, we've been missing something for a long time. Let's get back to this earlier way of thinking about the world, right? Which again was, we had gone into this kind of period of maintenance, if you will, where not a lot was changing technologically, and it was disrupted finally by the Black Death, and that brings on the Renaissance, which means rebirth, right? So there's this rebirth of learning and empiricism that had been set aside for a long, long period of time. And that Renaissance comes to an end, and the Enlightenment begins around as we move from a systemic belief reason and empiricism becomes even stronger, and we begin to kind of we continue to throw off some of the traditions of the previous period. A big turning point back here again is, like Martin Luther, breaking with the Church of Rome, right? So there's all these traditional society, social orders that are being just torn apart. And so the Renaissance, we begin to explore empiricism. We begin to look back at this earlier period, leapfrogging back in history. And then the Enlightenment is when we really embrace reason, and we really begin to believe that human beings can actually, kind of take control of their destiny. And it is in this period that we have the Industrial Revolution. And so the Industrial Revolution really begins with the invention of the steam engine back in, I think, the 1720s. And prior to the invention of the steam engine, which is a really crappy, relative to what we have today, really kind of crappy mechanism. But if you wanted to move something, you had to either, use your muscles, right, or some big animal, or you had to be near water that could, turn a wheel that could then, maybe run some sort of engine. So a lot of mills were on water so that they could use the water supply. But once you have the steam engine, you can now move away from water. You can move away from using animal power. You can move away from using human power. And there's this incredible explosion in what human beings can do in terms of manufacturing, in terms of transportation, right? The first trains are created in the late 1700s. So that you can have transportation, that you're not relying on an animal, right? And so transportation suddenly becomes available in a way that had never been before. And all of these factors start to come together to create wealth. And that's what triggers the Industrial Revolution, is this process of all these things. And so what happens is we become staggeringly wealthy relative to what we were, so we're in the Enlightenment in the 1700s now, the Industrial Revolution, just 50 or 100 years before. Whereas, 100 years before 1400, so in the 1300s, everything would look the same as they did in the 1200s and in the 1100s and the 800s. Nothing changed. But suddenly from that 1720 on, everything starts changing all the time, and everybody's getting wealthy. Now, not everybody, but I mean, society as a whole is becoming wealthier and wealthier in ways that we have literally never seen in human history, right? And it just takes off. Well, wealth, right, drives the ability, because human beings have a deep need to care for other human beings. And I do believe that sincerely. What we begin to see is this kind of undifferentiated institutions beginning to kind of bifurcate and break into different, more specialized into institutions. And so still very primitive, because back here, we're still very poor. But what we start to see are kind of breaking out of hospital kind of, sick organizations for the sick versus organizations for the mentally ill versus organizations for just the regular poor, right? So we start to see some organizational differentiation. And it is at around, now we're like in the early 1800s, and we're beginning to, we're beginning in the Enlightenment, we're applying reason to questions about health. So prior to, the 1800s, we've already talked about this, but, the tradition was we look back at what had been done, for the last 1,000 years. And even the Renaissance still reaching back to the Greeks, right? So we got Greek medicine, from classical Greek period 2,500 years ago. We can't do any better than that. But in the Enlightenment, we begin to start to explore things like, the microscope, and realize that we can look at the world through this microscope, and we can start to see there are microorganisms that you can't see with your unaided eye. So the same, technology that allowed people like Galileo to look out into the universe, now we can turn inward and look at and begin to discover microorganisms. And so we begin to start the beginnings of healthcare that actually works, right? So we have some traditions that work. We don't really know why, but we have just as many that don't work, and we use them too. And so we're beginning to see the application of science to medicine, and we see organized medical institutions, right? So we've talked a lot about all this stuff already. So I won't hash on it too much, but I really just want you to connect together here this explosion of wealth that happens after the 1750s and onward, and how, as a result, we see changes in how healthcare is delivered, right? And so these organized medical institutions, we begin to see in the 1800s, 1850s, right? Healthcare is beginning to start to have some things that actually work. We are beginning to organize physician training, as well as, and as we progress into the later 1800s, we see the professionalization and diffusion of knowledge, and the professionalization of medicine, and really importantly for this chapter, the professionalization of nursing. Because when we talk about inpatient care, we're really talking about care given, by a physician, but overseen by nurses. So the inpatient side is really run by the nursing staff. And physicians come in, they do their, they give their orders, they do their, incredible treatments, but then it's really the nurses that manage the experience of the patient for the rest of the time. And it is, you get admitted to a hospital because you require a high level of monitoring and care by nursing staff. Otherwise, today in particular, you just go home, right? And that's what we talked about in the outpatient chapter. So we see these advances in medical training, right? And what we see are hospitals as we approach, into the 20th century. We discover antibiotics, we discover, the microbiome, we discover germ theory. In this period, we're kind of figuring out just by practice and trial and error that, if we wash our hands and we clean, we're less likely to pass on germs, which we really didn't we kind of figured out the cleaning stuff before we figured out why the cleaning stuff worked. And it was because, you're trying to get rid of the bacteria that accumulates on your hands and gets transmitted by blood and all the, fluids. And then we have, coming up into today, right? So into the middle of the 20th century, we have, hospitals that are organized around medical training. Medical training becomes integral to the hospital. So almost all physicians are trained in hospitals today. That is their training ground, as well as nurses. And then, as we move forward, we have the advance of health insurance, and health insurance really becomes a means of financing the advancements of technology, which we've talked about already, and what really becomes the miracle of the healthcare system that we have today. As imperfect as it is, what we have today is going back to our ancestors in 1600 or even 1800, right? The medical system that we have today would look like something out of mythology, right? It would look like magic, right? To our ancestors from 200 years ago. So I want to talk today about the growth of hospitals first. We've got a little bit, so we're going to be very focused on hospitals. We'll talk about long-term care shortly, and I think 2 chapters we'll get into long-term care. So this inpatient care portion is going to be very focused on hospitals. So we've talked a lot already about advances in medical science, right, and technology. And so I've kind of rehashing a little bit of that. Medical education really evolved, right, in the early 20th century as we formalized medical education, and it became much more regulated and centered on the hospital, right? today I want to talk about advances in nursing. We've talked a lot about health insurance and how health insurance basically allowed the financing of all the incredible advances in medical technology. And I want to talk a little more about the emergence of the federal government and how the federal government really impacted the growth of the hospital industry in the United States. So let's talk a little bit about nursing. And you can't talk about nursing without talking about the founder of modern nursing, who is Florence Nightingale. Florence Nightingale was born in Florence in 1820 to a wealthy British family. She grew up in England, though, and she should have been a rich debutante young lady, getting married off to a wealthy, educated husband. She was, in fact, offered that opportunity, and she said, "No, I want a life that would have more meaning to me. I want to pursue a life of service as a nurse." And over the objections of her family, she went to London, went to a primitive nursing school, and began working in a hospital for governesses, I believe, that had become ill and unable to care for themselves. She showed incredible talent, and of course, being of upper class upbringing, was still tied into the elite circles, and made a name for herself in nursing. And at a young age, at only early 30s, the UK, the Great Britain, was in a war with Russia for the control of kind of what used to be the Ottoman Empire, and in particular Crimea, which you may have heard of in the news relatively recently, with Putin taking back or kind of annexing Crimea back to Russia again. So what was reported was the conditions so there was the British Army was off in the Crimea fighting the Russians, and the conditions reported back in the military hospitals were horrific. They were very badly run. People were suffering, and so the civilian leadership in Great Britain called on Florence Nightingale to go to the Crimea and see if what she could do to try to implement modern, and I'm using scare quotes here, nursing standards in these military hospitals. So she arrived. She was astonished by how horrific the conditions were in the military hospitals, and she brought a team of, I think, 30-ish nurses with her, and they began to try to implement basic sanitation and basic caring to the students. Not to the students, to the soldiers. Some 18,000 British soldiers at one point were languishing in these military hospitals. The conditions, as I said, were terrible, and most of the soldiers were actually dying from diseases related to filth, like cholera and dysentery, rather than battle injuries. Now, this was true. I think I've said this previously to you all. This was true well into the 20th century. It wasn't until the Korean War, so in the 1950s, that we saw deaths from disease be outpaced by deaths from battle injuries. Historically, most soldiers died from camp diseases like cholera and dysentery because of a lack of sanitation. So Florence Nightingale went, and this is still kind of pre-germ theory. So all she understands is cleanliness is next to godliness, and so she's just trying to create a better environment. But she was tireless. She was relentless in her pursuit of caring for the soldiers, and she would work long days and well into the night. And in the night, she would carry a lamp to continue her rounds and checking on the soldiers. and she earned the title "The Lady with the Lamp." And today, nursing still uses the lamp as a symbol of their profession. So many of the nursing pins that you'll see, so when a nurse gets their RN, they get a nursing pin, and many of the nursing pins integrate the lamp as a symbol of caring. So she transformed hospitals in the military system, and after the war returned to England and continued to campaign to improve military medicine and nursing as a whole. She became an early statistician, so not just a clinician, but a statistician and what we would call today a health services researcher. And she transformed not only military hospitals and military nursing, but the whole field of nursing through her tireless efforts. She published a number of books in her lifetime, including notes on nursing, what it is and what it is not. Right, that's pretty basic. This was published in 1859 and kind of became the foundation for nursing education for the next 75 years or so. In 1860, she founded the Nightingale Training School at St. Thomas's Hospital. And her influence extended across the ocean to the United States, where in 1873, 3 Nightingale schools of nursing were founded, one in New York, one in Connecticut, and one in Boston at Mass Gen. So right in our own backyard. But by 1900, there were more than 400 nursing schools in the United States, most of them following the Nightingale approach. So just talking about nursing as a profession and how it fits into kind of the inpatient world, again, early nursing schools were primarily kind of an apprenticeship program similar to physician education, right? So, and even today, when I talk to some of my physician colleagues, what they describe is very much an apprenticeship style of learning. Now, they do a lot of book learning alongside that, but they do a lot of C1, See one, try one, teach one is the mantra. So you see somebody do something, a procedure, you do it on your own, and then you teach someone else. That's the kind of the progression of physician training. And nursing training is the same, was then and still is today. As the nursing profession continued to professionalize alongside the medical profession, right? State nurses associations were organized, and licensing, and this is in the United States now, licensing was implemented at the state level. They initially called registration. So you become a registered nurse when you pass your nurse licensing board. So through the 20th century, professionally trained nurses early in the 20th century and up through the early 20th century, professionally trained nurses, they'd get their training in a hospital, but the hospital was really just a training ground for their future profession, which was really private duty. So you get hired by a wealthy family to come take care of a sick grandma, grandpa, children, whatever, in the home, right? So it's still this outpatient focus. But it was in the 20s and 30s that hospitals began to kind of evolve into these higher quality professional organizations, and professionally trained nurses moved from the outpatient setting back into the inpatient setting where they had trained. And so that's kind of the connection here to the inpatient setting, like we've been talking about, really didn't kind of kick in until the 20s, when technology had to be centralized, right? When technology actually could work and do something. So the hospital went from being a place where poor people who couldn't afford to have private duty nurses, sent their family to die, alone, or in this industrial kind of settings, to this high tech world that we have in inpatient care today. Nursing continues to evolve, higher levels, and we've talked about this, higher levels of advanced education and specialization. I mean, nurses all the way back into the early 20th century were administering anesthesia, and that has now advanced to a master's level nurse, the CRNA. And so forth. So nursing continues to kind of be primarily institution based, though we are also, along with the kind of the explosion of outpatient, this outpatient revolution I talked about last time, we're seeing more nursing roles, particularly in population health and population management, where they look at, and we'll talk more about this in the next chapter in managed care, where they use their medical skills to provide support to patients in an outpatient setting. Nursing research continues to be focused on the improvement of quality of care, and you heard quite a bit about that in the video on innovation. If you haven't watched that yet, you should, because there's a quiz on it. So now I want to transition to talking about kind of the federal government and its role in the growth of hospitals. If you grew up today, your age, my age even, we remember the federal government. We have always experienced the federal government as a very powerful entity with an enormous amount of resources. And it's almost like, why does state governments exist? Why don't we just have the federal government? Well, I talked to you a little bit about, the way back at the beginning of the semester, what, a week and a half ago, about the structure of the U.S. system, which was meant to keep different parts of the government in tension with each other. And so part of that tension was federal versus state. So the federal government was really designed to be quite weak, as originally written under the Constitution. And it was up through World War I. One of the things in my mind, again, because I'm an economist and a finance guy, one of the things that triggered the change in power structure and power dynamics between the states and the federal government was the implementation of the federal income tax. So the 16th Amendment to the Constitution, which was passed by Congress in 1909, ratified in 1913, allowed the federal government to create a federal income tax, which in the past was regarded as unconstitutional. The ability to tax at the federal level is key to the centralization of power that we see today in our system. The federal government benefits is able to tax across the entire country, and tax and borrow, without getting into a lot of detail about that. But that is where the power of the federal government comes from, because the federal government then can turn around with its enormous taxing capacity and implement different programs like Medicare and Medicaid, but also the Hospital Survey and Construction Act of 1946, also known, or better known, I should really say, as the Hill-Burton Act. And so the Hill-Burton Act allocated federal funds. So all the money now that we've got flowing into the federal government through the income tax program. Prior to the income tax, the federal government primarily got its money through tariffs on imports, and liquor taxes, and a few other kind of odds and ends. Never could have had the kind of structure that we have today, where the federal government has its fingers in so many different parts of the economy. So suddenly the federal government has all this money. It's post World War II. We're really deeply believing in the power of the government, federal government in particular, to make a difference in our lives after, successfully prosecuting World War II. We could do anything, right? That's the kind of the culture of post-World War II. And so the federal government decides, Congress decides to allocate money to building hospitals, because we need to, enter the space age. And so we're going to get hospitals out into the boonies. We're going to move up. So the goal was to have 4.5 community hospital beds per 1,000 people in the civilian population. And we reached that goal by 1980. So from 46 to 80, it took to get there, but it did get there. And along with that, of course, I'll talk in a minute, is Medicare helping that too. Some 40% of new beds built were funded with Hill-Burton Act money. So they subsidized the building of hospitals even in remote areas, and we're going to see that when we look at New Hampshire in just a second. So alongside the Hill-Burton Act, of course, is the Medicare and Medicaid programs that funnel money to the elderly who need a lot of healthcare. And suddenly there's this money available, both in terms of direct subsidies to hospitals to be built, communities to build hospitals, but also to pay for the use of the hospitals once they're built. So there's this very profitable nexus between those two government programs. And of course, we also have talked about private hospital insurance that came out of the 20s. And so today, even today, it's normal for hospitals to get 30 to 60% of their revenue from Medicare and Medicaid. So the government today, the federal government today, continues to play a major role in the financing of inpatient care and the existence of hospitals. Now, the federal government had a major role in the growth of hospitals, and it has also had a major role in the closure of hospitals. And last time we talked about the creation of PPS. So I'm not going to go into that a whole lot again, right? Let's just rehash here. PPS starts in 1983. It's the result of the Tax Equity and Fiscal Responsibility Act, TEFRA, of 1982. And it takes away that cost plus reimbursement that we had talked about that made, Medicare reimbursement was really fat for hospitals. Hospitals made good money on Medicare. Today, they're like, Medicare kind of stinks. Whereas pre-1980, Medicare was really good, really good money, right? You could really build your hospital on Medicare revenues. Today, you can basically keep your doors open, maybe, if you can keep your Medicare revenues from occupying too much of a percent of your overall revenue. So really, hospitals that have a 60, 70% Medicare, Medicaid, tough. A lot of them don't make it. And in fact, as reimbursement was no longer based on cost, it encouraged the shift to shorter stays, which we talked about in the outpatient care, right? Shorter stays means fewer beds necessary. If we have fewer people staying, we don't need as many beds. If they have a shorter stay, we can turn over those beds faster, right? Fewer beds means fewer hospitals. The stays that happen are now much more intense. So hospitals that weren't well run to handle more intense care and relied on these long, low intensity stays collapsed. And so what we saw in the decade of 1990 to 2000 was about 200 rural hospitals and 300 urban hospitals closed as they just burned through their cash and just couldn't make it. So we've already kind of talked that issue. Here is some actual financial data from Tenet Healthcare. Tenet Healthcare is the second largest hospital chain in the United States. They actually have the most hospitals, but by revenue, they're the second largest after HCA. HCA is the parent company of Portsmouth Regional Hospital here in Portsmouth, Frisbee Hospital in Rochester, and Parkland Medical Center in Derry. So looking at this is just Tenet, and I was talking about like what percent of revenue. So this is a breakdown. So Tenet has a hospital operations division. They have an ambulatory care division, a consulting division, and some other stuff is mixed in here. That's really just accounting stuff. But from their hospital operations, they're breaking out their revenue in terms of how much revenue do they get from Medicare, Medicaid, from managed care, which we'll talk about next time, which is we're really broadly saying from managed care insurance plans, from the uninsured, and then indemnity, which is kind of the classic major medical, so the non-managed care, classic fee-for-service health insurance, which still exists, but you can see it's a tiny percent of their overall revenues of so they from their hospital division, they make $13.6 billion from their hospital division. About 3.8 billion of it comes from Medicare and Medicaid, right at about 30%, right? So this is what I said to you a minute ago. So 30% is pretty good for a large health system. And this is a for-profit hospital system. So your book's got a lot of data in it about a variety of different things. I'm going to just focus on a few things that I think are important for understanding when you talk about a hospital. You're just like, well, what are the key statistics you want to understand about a hospital, get a sense of how big are they, right? Well, first thing you're going to ask is how many licensed beds do they have? This is the number of beds that the state has said that the hospital is authorized to use. Now, that isn't the actual number of beds that they are using. So the actual number of beds they are using are called staffed beds, right? So these are available to actually be used. So they actually pay nurses to monitor and be present to run this number of beds. And so, a hospital might be licensed for 400 beds, but they may only staff 250 of those beds. And that number is falling most likely because of all the pressures we talked about, with PPS, with advances of medical technology that allow us to do a lot more care on the outpatient side. Another important number is average daily census. So this is the number of patients that are actually staying in your hospital on any given day, right? So you want to know, well, what's the average daily census? Oh, it's, my average, if somebody tells you the average daily census of this hospital is 150, then you're talking about a fairly large community hospital. If they tell you it's the average daily census is 7, then you're probably talking about a critical access hospital in a rural area. Occupancy rate is the average percent of the staffed beds that are actually filled with a patient staying overnight. So if you're staffing beds, you're paying to have nurses physically present. You want to have what we call in the industry a head in a bed, because that's how you make money, is by filling those beds, right? By admitting patients and having them get cared for by your nurses. Otherwise, you're wasting nursing. You're paying for very expensive nursing staff who are, not taking care of patients. Another important metric for the inpatient side for a hospital is the number of discharges. And we could talk about admission is when you go into the hospital, discharge is when you leave the hospital. We typically use discharges because most admissions, all admissions come with a discharge, even if you die. If you die, you get discharged to death. So it still counts as a discharge. So we count those. Why would we prefer discharges over admissions? Well, if you have an OB ward, you have 1 come in and 2 or maybe 3 or sometimes 4 go out, right? So you have 1 mother admitted, 1 future mother admitted, mother and baby discharged. So 2 discharges versus 1 admission. So we typically rely on discharges rather than admissions to kind of get that raw number of cases cared for. And then we have our average length of stay. And this is an important number, particularly for critical access hospitals. But this basically is saying, how many nights does the average patient stay in your hospital? A longer length of stay indicates typically a more intensive level of care. A shorter length of stay indicates a shorter or lower level of intensity of care. I stole some facts from fast facts from the American Hospital Association to give you a sense of kind of the size of hospitals across the United States. So 84%, or about 5,100 hospitals, are regarded as community hospitals. That means they're not owned by the federal government. So they're not a VA facility. They're not an Indian Health Services facility. They're not a military health system facility, right? They're owned by some private entity. And that could be both. The bulk of this 5,100 are not for profit or nonprofit. That's the same thing. People just kind of have a preference. So the bulk of these facilities, something like 70%, are not-for-profit entities. The other 30% are for-profit hospitals. So Portsmouth Regional, being part of the HCA system, is a for-profit hospital. Wentworth Douglas in Dover is a not-for-profit hospital, and now, was up until recently an independent hospital, now part of the Mass General Brigham system. So we have 84% of hospitals are these community hospitals of various sizes. Then we have psychiatric hospitals, so non-federal psychiatric hospitals. Then we have federal government hospitals, which include, again, like VA medical centers, Army hospitals like the ones I worked in. And then we have kind of some other cats and dogs. So some more facts about healthcare, about hospitals in particular. So like I said, most most community hospitals are not-for-profits. I said 70%, so it's actually 57%, I guess, if you count in state and local government hospitals. So if you incorporate state and local government hospitals, like, for example, anyway, so you can see this ratio, community hospital ownership. So what's really interesting, and I'll point this out a little bit when we look at the New Hampshire map of hospitals, is just how many hospitals have moved from being independent, standalone facilities like Wentworth Douglas, for example, and have now joined up into systems. So Wentworth Douglas went from being an independent facility to being part of the Mass General Brigham system. Frisbee Hospital was a not-for-profit, standalone independent hospital. It recently sold itself to HCA and is now part of the HCA system, for example. This is a fast-moving train. I think this number is going to continue to, I know this number is going to continue to fall. I'm wondering when that number, goes to like 10% and we get like 90% or 95%. And not only that, until we see systems kind of combining and we just get, my thinking is, we're going to see eventually that the hospital industry is run by a handful of very large systems. We'll see. Maybe, maybe not. But the trend is definitely there. Most hospitals are urban, but we have a significant number of rural hospitals. And of course, in New Hampshire, that's that's the reality. So let's look at New Hampshire for a minute, because you're going to UNH. So this graphic is from the New Hampshire Hospital Association that I do a lot of work with. Good folks over there. And this graphic, the little red buttons represent critical access hospitals, and the green green buttons represent PPS hospitals, and then the kind of swamp green, yellowish green buttons represent specialty hospitals. So, so I'm going to talk about what a critical access hospital is, but just for now, think super small, 25 beds or less, super small. So New Hampshire has 26 critical access and prospective payment hospitals. Prospective payment hospital is your standard community hospital that takes prospective payment, the thing we've been talking about, where they take a payment based on a DRG. So in the industry, when we're talking about hospitals, we kind of distinguish community hospitals as PPS hospitals or critical access hospitals. So the vast majority of hospitals are PPS hospitals, but a lot of small rural hospitals are critical access hospitals, as you can tell here. So we have kind of where is Spear? That's Spear Hospital is in Plymouth. Spear Memorial is in Plymouth. Kind of past here, you're heading up into the North Country, right? And so this is really rural up here. And in fact, these three hospitals, recently, as well as this one, Littleton. So Androscoggin, Littleton, Weeks, and Upper Connecticut all initially formed a little system, the only system of critical access hospitals in the entire country. They formed like a little alliance. Then they actually merged into a system. And then Littleton dropped out, but the other three still remain. So we have up here really rural area, not a lot of care available, right? Down here we have, we're down in the much more populated area, Seacoast, New Hampshire over here, right, where we've got Frisbee and Rochester, Wentworth Douglas that I talk about a lot because it's in our backyard, Portsmouth, and of course Exeter. And then we have some other specialty hospitals over here that are either mental health hospitals. So 29 is the New Hampshire Hospital, which is a state-run mental health or behavioral health hospital. We also have Hampstead, which is a 27, which is also a behavioral health hospital. We have a couple of rehab hospitals, and we have the Veterans Medical Center, which is not really a hospital, so I'm not sure why they have it on here, because it's all outpatient. But you can see kind of the distribution, right? Rural hospitals tend to, rural areas tend to be serviced by critical access hospitals. I mean, if you lived up in this area and you didn't have access to Upper Connecticut Valley and you wanted to have your baby, and stay up here, this is where you're going to go, or you're going to have your baby at home. Right. So if you wanted to have access to a hospital, critical access hospital provides that availability of inpatient care. Some data about our PPS hospitals. So these are the 13 larger hospitals in the state. So it gives you their name, their location, number of staffed beds, right? So staffed beds as opposed to licensed beds. So all of these facilities are licensed for more beds than they actually staff. The number of discharges. So this gives you a good sense of how busy are they, right? How many patients are being discharged? This gives you a better sense of what's going on in the facility. Patient days. So this is we almost call this patient nights, because for it to count, you have to spend a night in the hospital to count as a day. And then our average length of stay. So we've talked about each of these things, right? So average length of stay, how many, if you're admitted to Catholic Medical Center, on average, you're going to be there for 5.6 days, right? And so it ranges from, who's the highest? Looks like Dartmouth Hitchcock, which makes sense because Dartmouth is our one academic medical center, right? So Dartmouth is a little bit different than the other 12 because Dartmouth is built around the Geisel School of Medicine, the Dartmouth Medical School, right? So it is a teaching hospital and a academic medical center. So it actually, you've got some information in your text, and I'm not going to go into it in the lecture, about the fact that it gets, compensated differently than you say Eliot, which is not a academic medical center, or any of the rest of these are not academic medical centers. Parkland and Catholic both have residency programs. So they're teaching hospitals, and there are some special benefits that they get in terms of reimbursement because they have, I believe they both have family practice programs. So they have physicians who are training to be family practice or family medicine doctors. But Dartmouth has the full range of residency programs and fellowship programs. So you can see it's also the largest. It has the most discharges. It has the most patient days, and the occupancy rate, interesting, is pretty low at some of these places, right? So they're staffing a lot of beds, but their occupancy rate is quite low based on their discharges and their patient days. And then finally, their gross patient revenue. I'm not going to get into a discussion about this. If we want to get into a lot of depth, if you're fascinated by these numbers, come take my finance class and we'll talk at length about it. But I will just tell you, gross patient service revenue, or it's gross patient revenue. We usually call it gross patient service revenue. GPSR is monopoly money. It is only loosely related to how much money these hospitals actually bring in. I would cut these numbers by about 60% to get a more realistic number of how much they actually get. Why is that? Because when we've talked about insurance, one of the things insurance companies do, and we'll talk more about this in the next chapter, is they cut or they make deals with the hospitals for discounts. And those discounts are in the range, wind up being in the range of 50% or so. So Catholic Medical Center really has an annual revenue of about 700 million, not 1.4 million. 1.4 billion, not million, because these are in thousands. So, Cheshire brings in probably around 300 million in actual net patient service revenue. All right. So we've talked about PPS. Those are the bigger community hospitals that provide, a range of services. They are quite high tech, right? Catholic Medical Center is a leading heart center. A heart care center. We have 13. But what about these 13 critical access hospitals? So to be a critical access hospital, you have to have less than 25 beds. You have to have an average average length of stay of less than 3 days. And you have to be 50 miles from the nearest hospital. This one can be waived. The distance one can be waived by the governor. But the other two hold really tight. So 3 days or less average length of stay means that you've got patients who are not staying for very long. If they are seriously ill, they get transferred to one of the community hospitals, or Dartmouth or Mass General. What's great about being a critical access hospital, you get cost plus reimbursement from Medicare. So it's a little bit fatter, but these facilities are still struggling, despite the fact that they make a little more money from Medicare. Really tough. Most of these facilities have very high Medicaid and Medicare ratios, much higher than our community hospitals. Some other New Hampshire hospitals include psychiatric hospitals. The New Hampshire State Hospital is the main one, for seriously mentally ill patients. A lot of our community hospitals have a ward where they have some number of beds that they provide behavioral health, inpatient behavioral health. New Hampshire State Hospital is run by the state, hence the name. And then Hampstead Hospital is a private behavioral health hospital. We have some rehabilitation hospitals. So these have a lower acuity. These are not acute care hospitals. So our PPS hospitals, our critical access hospitals, that's where you go when you first get sick. These hospitals are meant to provide a high level of intensive rehabilitation after you've been sick. So if you have a stroke, for example, they'll stabilize you in an acute care facility, and then they will transfer you, if you need it, to a rehabilitation hospital. Or if you have a spinal cord injury, for example, you would be transferred to a rehabilitation hospital where they would give you that intensive level of care. And it's measured in, I believe it's 3 hours a day of intensive PT and OT and other services. And then finally, we had the Manchester VA Medical Center, which, as fabulous as it is, isn't a hospital because it doesn't have inpatient capability. All right. I want to talk to you briefly about governance and how a hospital is organized and run. So every corporation, and not-for-profit and for-profits alike, are corporations. So Wentworth Douglas is a not-for-profit hospital, right? Not-for-profit corporation, but it's still a corporation. it has a board of trustees, and it's a little bit different now that they're part of a system. So a better example would be Exeter Hospital. Exeter is part of the Exeter Health Resources System. And so the Exeter Health Resources System has a board, and it's called the Board of Trustees. And when they deal with Exeter Hospital, there are two chains of command, if you will, in the hospital. So on the one side is kind of your typical, what you would typically imagine for a corporation. A shoe manufacturing company like Nike, for example, would have a board of, in this case, because they're for profit, they're called a board of directors rather than a board of trustees, but they have a board, right? And then the CEO reports to the board, and the CEO of Nike, much like the CEO of Exeter Hospital, reports to the board and then is responsible for the operations of the organization. The CEO is an employee of the hospital, and the board appoints the CEO. So the board's only real hiring and firing that it does is it hires and fires the CEO. And then the CEO hires and fires everybody else and is responsible for everything else about the organization. So the CEO then creates a C-suite staff of the chief financial officer, and in the case of a hospital, you'll have a chief medical officer, a chief nursing officer, chief operating officer, right? And they're responsible for both the day-to-day operations all the way up to the strategic planning for 5-10 years out. And included in this side is all the nursing staff, right? All the nursing staff, all your X-ray techs, all your clinical employees who are not individually licensed to practice on their own. And then of course, all of the non-clinical staff, like your patient service reps that sit at the front desk, right? So the hospital CEO is responsible for running the operation of the hospital. A lot of hospital CEOs historically have been administrators. Now they're more and more nurses or physicians, but regardless, they're responsible for the operations of the organization. Now, what about this other half, right? Well, you have the medical staff, the organized medical staff. So a hospital has doctors that provide care in the facility, and this is called the medical staff. And there is a chief of the medical staff that kind of represents the interests of the medical staff. And it's an elected position, elected by the physicians and depending on the bylaws, other providers that have privileges in the hospital. So what does it mean to have privileges in the hospital? Well, you can't just, even if you're a physician, you can't just admit a patient to, say, Exeter Hospital or Wentworth Douglas or Portsmouth, right? You can't just call up and be like, hey, I'm admitting, Bonica, he's sick. I'm going to admit him. And the hospital's going to say, now, who are you? And we don't have you on our medical staff. You don't have privileges here. You don't have the right to admit patients to our hospital. You don't have the right to order our staff to do things to patients. So physicians and other providers that have privileges to practice in the hospital. Remember the doctor's workshop concept, right? So this side is responsible for maintaining the workshop, making sure all the tools are there, making sure the schedules are on, keeping the lights on, the water running, and so forth. These are the people that are coming in and doing stuff in the doctor's workshop, right? These are the doctors in the doctor's workshop. And you have to be part of the club, right? Part of the medical staff in order to be able to come into the hospital and do things, right? And exercise your privileges as a physician or as a nurse practitioner or so forth. So the medical staff operates through the Medical Executive Committee, generally referred to as the MEC, right? And then there's a number of subordinate committees beneath that your book goes into, and I'm not going to talk about. But the main function of the MEC is kind of setting health policies, the medical policies in the organization. They work with, hand in hand with this side, right, in setting policy for high quality care. But probably the most important thing is they decide who gets to come into the hospital, who gets privileges, and whether we need to take those privileges away from somebody. So it's a what's, like Nike, right? You've got a board of trustees, and then they hire a CEO that runs the organization. Unlike Nike, the people who drive the business aren't necessarily employees of the hospital, and generally aren't employees of the hospital. It's called the voluntary medical staff. So that's one of the uniquenesses of hospital management. All right, last slide. I'm going to talk briefly about licensure and accreditation. So healthcare is governed at the state level. Physicians get their medical licenses from a state, nurses do, PAs, everybody who's got a license to practice medicine gets their license at the state level. Likewise, hospitals are licensed at the state level, not at the federal level. So you got to have a license to operate given to you by the state. The Department of Health and Human Services, DHHS, and its subordinate entity, the Center for Medicare and Medicaid, CMS, which I didn't write on here, certifies hospitals for participation in the Medicare and Medicaid program. Right, so you could be a hospital, get a license from the state of New Hampshire to open your doors, but in order for you to bill Medicare and Medicaid, you have to be certified by the U.S. Department of Health and Human Services. In order to be certified, you have to meet conditions of participation. It's basically proving that you're a well-run facility and you aren't dangerous, any more dangerous than any other hospital, because hospitals are quite dangerous. And if you meet the conditions of participation, then you get to bill the federal government. Now the key here is, I told you a minute ago, hospitals get somewhere between 30 and 60% of their revenues from Medicare and Medicaid. So they can't afford not to meet the conditions of certification. And so the federal government then has a very powerful tool for reaching down from Washington into, Berlin, New Hampshire, up to Androscoggin Hospital, Androscoggin Valley Hospital, right? All the way from New Hampshire, from DC up to New Hampshire, to tell Mike Peterson, the CEO, how to do business at Androscoggin Valley Hospital, right? And they have that mechanism through the conditions of participation. So it's a very powerful tool that the federal government has. So something to think about, right? And so you've got a couple of ways you can get accredited or meet the conditions of participation. One of which is to get accredited by the Joint Commission on the Accreditation of Healthcare Organizations, also known as the Joint Commission. Back in the day, they used to be known as JCAHO. Now they want to be called the Joint Commission. This is a nonprofit entity that sends a team of consultants out to a hospital to review your processes and procedures and determine whether you are a well-run hospital. And if they accredit you, then the CMS and HHS accept that as you are then deemed as having met the conditions of participation. All right, so that's our discussion for inpatient care, mostly focused on hospitals and how hospitals operate. Hope that was useful to you. There's a lot in the text that I didn't cover, so be sure to read the text carefully.